Okay, we will be going to the topic diabetes mellitus patient-centered approach, and we will be dealing with this in these subtopics like introduction, classification, evaluation, complication, and management. Okay, just we are going through the brief description on the definition of diabetes. Actually, it is a metabolic cum vascular syndrome. Mainly the process is metabolic, but it will lead to vascular thing, and the main etiology being hyperglycemia. Hyperglycemia, which will affect the disturbance of carbohydrate, fat, protein metabolism. And this hyperglycemia may be either due to decreased insulin secretion, insulin absence, or decreased action of insulin, or both. Okay, and this will lead to both small vessel and large vessel changes that we see as micro and macro angiopathy. Okay, and these are few things about the ancient things in diabetes. It was first reported in Egypt, and the literature is in 1552 BC, and it was described by Aratus, who first used the term this term diabetes. And first report from India came in 2nd and 5th century. It was by Charaga and Susruta, and they were able to identify diabetes mellitus and diabetes insipidus. And they defined two types of diabetes, lean and obese, and they found that it is difficult to manage lean diabetes. And few things about history of diabetes, and it was Paul Langerhans who suggested that pancreas contains some secretion that will control sugar values. And in 20 years later, a Polish-German physician, Oskar Minowski and John von Mering, removed the pancreas from a healthy dog to find swarm of flies in the dog's urine. Okay, and in 1901, Eugene Oppe is diabetes mellitus suggested that diabetes mellitus is caused by destruction of islet cells. And discovery of insulin, and the Nobel Prize for Medicine in 1923 went to discovery, and it was shared between Banting and MacLeod. Banting shared it with his partner Best, and MacLeod shared it with his friend colleague. A few words on epidemiology of diabetes. The salient features are that type 2 diabetes compromise majority, and in both developed and developing countries, type 2 diabetes is there. And in developed countries, type 2 diabetes is actually a disease of middle-aged group, and it is commonly seen in overweight and obese. And there is associated, there is a varying trend in type 2 diabetes in children, that there in European countries, it is more common in children. Actually, in India, we don't have much data to suggest that it is common in children or not. The worrying thing is it is occurring even in non-obese individuals and occasionally seen in children. There is articles suggesting that they are more prone to develop cardiovascular disease more than what the Europeans have, and microvascular complications are less. And just for completion, we need to know that there is a national program for prevention and control of cancer, diabetes, and cardiovascular diseases and stroke. And this was implemented in 2010 and running successfully to an extent till now. And the strategy is promoting healthy lifestyle through massive health education and health education. And the thing is that part is not completely true, because we know that the health education part in India is not that much good. And there is universal screening of adult for 5 years for these 5 diseases under this program, and they are successful to an extent in setting up NCD clinics at CHCs and district levels, and they plan to train more manpower and strengthening of tertiary care facilities for treating these diseases. And the status of diabetes awareness in India is only 43% of individuals have ever heard of diabetes. That's why I said that our mass media campaign is not a successful thing. Of 50% of the diabetic patients, they don't know that diabetes will lead to end organ complications. And more than 80% don't know that risk factor of diabetes, and 50% don't even know that diabetes, type 2 diabetes, at least type 2 diabetes can be prevented. And the diabetes control in India is only 20 to 30% of the patients have their HbA1c under control, that is below 7. And it may be partly our mistake and partly the patient's mistake, because actually in India, we don't follow a guidelines. Whoever treats, they put a guideline and they treat according to their way. But guidelines are there for us to follow. And management of other comorbidities like hypertension and lipids are not up to par with other countries. And more than 50%, this is a study done by Mohan sir and his daughter, and it is a multi-centric study, and this comprises of at least almost 1.2 lakh of patients all over India. This was done in almost 7 centers in India. And more than 50% of patients are not at all informed about the glycemic control. I know it is in a busy OPD in a primary care setting, it will be very difficult to explain all these things, but it will be good if we suggest these to patients. And few words on insulin. It is a polypeptide hormone. We know that and it has 2 chains, A and B chain. And regulation of insulin. The initiator of insulin secretion are glucose and certain amino acids, and the potentiators are glucagon, other amino acids, acetylcholine, GLP-1 and GIP. And inhibitors of insulin secretion, we know ghrelin, norepinephrine, and all. Okay. This is how insulin is secreted. Just briefing through it. When there is a glucose load, glucose enters through the via GLUT2 receptor to beta cells, and this leads to activation of glucose by glucose kinase enzyme, and this glucose is converted to glucose 6-phosphate. And once this glucose 6-phosphate is converted, it is finally breakdown to ATP, and there is an increase in ATP-ADP ratio, and this will lead to ATP-dependent potassium ATPase channel closure, leading to membrane depolarization. This will lead to calcium influx and calcium channel and release of insulin stored in the secretory glands. Okay, we will go through a case scenario. This is a 32-year-old male, manual labor, who comes here with his sugar values. His fasting plasma glucose is 138, and postprandial glucose is 188, and HbA1c is 7. Okay, whether he's diabetic or not. So we have to know what are the criteria. The diagnostic criteria for diabetes is symptoms of hyperglycemia with RBS or any sugar value or random blood sugar of 200 and more. Okay. And fasting plasma glucose more than 126, 2-hour plasma glucose more than 200, and HbA1c more than 6.5. I know majority of us will be knowing this. And there are few other terminologies which we must be familiar with, that is impaired fasting glucose, and it is fasting glucose between 110 and 126, and impaired glucose tolerance where the postprandial is between 140 and 190. And American Diabetic Association suggests that this IFG to be 100 and 126, but we usually follow this 110 and 126. Some labs follows the other value. So classification of diabetes, it is broadly classified as type 1, type 2, and other specific of diabetes and GDM. And this is different types of diabetes which we see in youth. This is very difficult thing to differentiate, so that I have made some case scenarios which will help us identifying this. Type 1 monogenic type diabetes, type 2 diabetes, and other form, which will be briefly speaking on FCPD. And this type 1 is not that much confusing, but this monogenic and type 2, which is an early onset type 2, is a bit confusing. This is a 7-year-old boy who presents to your OPD with all the classical symptoms of hyperglycemia, and he's having abdominal pain, burning, maturation. His fasting sugar and postprandial sugar are this, and HP 208 and 342. HbA1c is 10.1. Okay, this is how he came to you, and from the history we know that he is having the diabetes, and what the history we should elicit is whether he was having diabetes previously and whether he is on any medicines. Okay, with this history, his parents suggest that he's not having diabetes previously. So, and after going through the history of diabetes and its complications, we will finally go through an investigation part. On examination, his height and weight is this, and his BMI is 12.5. So his BMI is low, and there is no markers of insulin resistance, and he's having dehydration. All these suggest that he is having type 1 diabetes. So we will next go for a ketone bodies in the urine and beta hydroxy butyrate values in blood, which was suggested that is elevated. Lipid profile can be done to see whether the triglycerides are elevated, but the C-peptide values are the gold standard in this case patient because his fasting and stimulated C-peptide is very low. So this suggests that he has poor insulin pancreatic reserve, beta cell reserve. GAD antibody in a primary setting, I don't know whether we will be able to do it, and don't know whether it will be the patients will be able to afford it. But for completion's sake, GAD antibodies can be done. And this is the clinical scenario of a type 1 diabetes. This is a 15-year-old girl who presented to our OPD with 9 months of duration of diabetes. Because her age was 15, she was treated as diabetic, type 1 diabetic, and was initiated on insulin. But her sugar values are still high. That she's having 196 and ppbs of 320. HbA1c is very high. Here, we have to take a family history and go. The patient is with us, and we have to look for the routine examinations. Here, the main factor is she's having strong family history of diabetes, and this suggests that there is a possibility of not being type 1. So in her height and weight, the weight is 73 and height is 163, and her BMI is 27.5 and HbA1c is 9.8. We will go through all the other routine examination, and on examination we will see 4 markers of insulin resistance, and she is having acanthosis nigricans. So our investigations will be same as C-peptide, because we are suspecting type 2 diabetes in this patient because of this picture, because there is acanthosis nigricans and features of insulin resistance. And her fasting and stimulated C-peptides are fairly good. So the patient is having good pancreatic beta cell reserve. GAD antibody can be done, but for research purpose, with history and examination, it is almost sure that this is having early type 2 diabetes. And the same scenario when a 15-year-old boy present your OP with history of recurrent folliculitis on his back, and his fasting sugars are 205 and 321, and his HbA1c is 9.1. And she was detected to have diabetes at the age of 30 on evaluation for recurrent UTI. But the history that her mother, maternal grandmother, maternal aunt and sister all having suggests that it is not type 1, not type 2. So on examination, her height is 157, weight is 52.4, and BMI is fairly okay, and all examination were normal. Once our other profile of investigation are done, the C-peptide values will give you that the peptide is normal. That is fairly good pancreatic cell reserve. And this is how monogenic diabetes or MODY occurs. And the diagnostic criteria is age less than 25 and autosomal dominant transmission. That is, one side of our family members of 3 generations will be involved. There will be ketosis, and this patient will be benefiting with OHS at least in the early period of our disease. And this criteria is not relevant now because genetic analysis is recommended now. This is another case. This is a 20-year-old man who presented to you with 2 years of duration of diabetes. The history that he is having recurrent abdominal pain, passing oily stools on and off will suggest that he is having a pancreatic diabetes. So he's having this for past years, but make sure that he is not a smoker and alcohol consumer from the history. So he's on OHA, but has been on poor control. This examination will give you a clue that his weight is low, height is 168, his BMI is low, his sugars are very high, and his HbA1c level is almost 10 point. And this investigation, which will help you in diagnosis, is abdominal X-ray or USG. And this is called as fibrocalculous pancreatic diabetes. This is commonly found in tropical countries, and it is common in Tamil Nadu and Kerala. And this patient should be treated as type 1 diabetes. And this is a few words on late autoimmune diabetes of adults. It's otherwise called as 1.5 diabetes. And the criteria is any antibody, autoantibodies associated with the type 1 diabetes and age at onset more than 30, and will be free from insulin at least for the 6 months. And C-peptide will be low. Okay, now coming to, after we have finished that, we'll be coming to evaluation of a patient with diabetes. I will be dealing mainly with type 2 diabetes because it is most common and it's on the rise in our country. Not even in our country, in every country it is on the rise. And from the history, we will ask for the classical symptoms of diabetes like frequent urination, excessive thirst, and excessive hunger. This frequent urination may present as polyuria or nocturia, and we will have to take a detailed history whether to make sure that the patient understand what it means, and what the patient tells, we have to make out it is polyuria. And excessive thirst, majority will say that their throat is dry at night period. And there will be excessive hunger. That will be they will present with gastritic like feeling, and there will be weight loss, delayed healing of wound, tiredness, itching in the genital area due to fungal infection, and tingling and numbness, and visual disturbances. Of the 60% of the patients who will not have any other symptoms, they will be detected to have diabetes when we look for any other diseases. We will have to take a detailed family history to differentiate whether it is maturity onset or early onset diabetes, type 2 diabetes. And medical history with the previous treatments outcome and present treatment, drug allergy in product, history of hospitalization, hypoglycemia, and other any other complication associated with it. And ask for symptoms suggestive of complications such as facial puffiness, pedal edema, nocturia, frothing of urine, angina, effort intolerance, claudication, sensory impairment, and sexual dysfunction also. Physical examination. The physical examination, as usual, we will do height, weight, BMI, waist, circumference, blood pressure measurement, look for postural variation, and and abdominal examination, thyroid examination for any other endocrine diseases, and skin examination to look for features of insulin resistance. Fundus examination should be done for each and every patient. Don't miss dental or oral examination because it may be a source of infection in diabetic patient. And comprehensive foot care. It should start from the day 1 of diabetes with inspection, palpation, ABP, angle brachial index, angle and knee jerk, proprioception, vibration, and monofilament sensation. The investigation panels for the first visit once in 3 months, once in 6 months, and annually. This is usually followed guideline, but it has to be individualized because most of our patients may not be affording each and every investigation, because this investigation panel will be costly for these patients. In primary care, it will be difficult to do all these things. In the first visit, it is usually asked to do HbA1c, plasma glucose levels, lipids profile, liver function tests, renal function test, urine albumin creatinine ratio, hemogram, ECG, chest X-ray and echocardiogram, and thyroid TSH values if it is indicated, and if the history suggests it is there, and retinal examination, foot X and oral examination. Once in 3 months, HbA1c and plasma glucose should be repeated, and once in 6 months, HbA1c, plasma glucose, and serum lipids. Annually, all these tests should be done repeated. And I don't think a majority of our patients will be affording this. Now coming to complications of diabetes. Diabetes complication can be divided into acute and chronic. Acute can be metabolic and infection, and chronic can be vascular. Of this acute, DK, HHS, hypoglycemia, lactobacillosis are there, and infection. So we will go through this one by one. So infection and diabetes, it is not merely the hyperinsulinemia that is causing diabetes, this infection, partly patient's part and partly their immune response. This common infections which we see is urinary tract infection, which may present as either cystitis, pyelonephritis, or renal abscess. Whenever a patient, diabetic patients come to you with fatigue and fatigue, always think of UTI in a diabetic patient. And respiratory infection, this common bacteria or common commensal bacteria may get notorious when we have uncontrolled diabetes or when we have a pure immune response. That can be a Staph aureus pneumonia, gram-negative pneumonia, lung abscess, tuberculosis. It has been seen that tuberculosis is much more prevalent in diabetic patients because of their decreased immune response. So always think of tuberculosis when a patient present with prolonged fever and present with PO in a diabetic patient. Skin and soft tissue infections are common in diabetic patients. It may be either folliculitis, carbuncle, pharyngeal, anything may be the surgical wound infection, and foot infections are also common. Abdominal infections are common. Whenever we have a patient with recurrent STI and chalcosione, always think of refractive error and uncontrolled diabetes. Oral infections should always be looked for because periodontitis are common in diabetic patients. Now we will go through a case scenario. This is a 12-year-old boy who is brought with complaints of vomiting, abdominal pain, and breathing difficulty. And his parents states that he has been complaining of excessive urination and thirst during the last few weeks. On examination, the patient is drowsy and he's having acidotic breathing. And his BP is 100/60 and pulse rate. There is tachycardia, there is tachypnea. His capillary blood glucose is very high. It is 520. So from these symptoms, it is suggestive that he is having diabetic ketoacidosis. So we'll go through details of diabetic ketoacidosis. Diabetic ketoacidosis, it is a state of metabolic decompensation which occurs due to insulin deficiency, and the three components are hyperglycemia, ketosis, and metabolic acidosis. The classical symptoms can be either due to hyperglycemia or neurological symptoms or gastrointestinal symptoms. The gastrointestinal symptoms, the patient may present as acute abdomen. Always think that nausea, vomiting, and acute abdomen in a lean patient with these features, with sugar values high, think of diabetic ketoacidosis. And the symptoms, it may develop within hours or days. Okay, respiratory symptoms also common in these patients. They will have a rapid deep breathing, that is Kussmaul respiration. Features of dehydration will be there, and changes of mentation and other features of hypothermia, hyperapnea will be there. Smell of acetone in breath is not usually seen, but may be seen in some patients. This is a formula to get corrected serum sodium levels. We can use this formula for fluid correction and sodium correction in diabetic ketoacidosis. The mainstay of treatment is intravascular fluid correction, electrolyte correction, acid-base balance, and initiation of insulin to treat the metabolic catabolism. And we have to monitor the patient, treat the precipitate underlying cause, and prevent complication, and provide education follow-up of this patient. Okay. There are diabetic ketoacidosis may be mild or moderate and severe. In mild, we can treat them in an observation basis, and we can give them added salt fluid. Insulin may be initiated at as 0.25 to 0.5 units per kilogram and may be repeated every 2 to 4 hours. Monitoring blood glucose should be done every 2 to 4 hours. And they can be kept in hospital for 6 to 12 hours. Once they are okay, they can be left. But moderate and severe ketoacidosis cannot be treated in a OP basis. It should be treated in an IP setting, preferably in a ICU setting. And the things to be looked for are same, but the frequency should be more and continue insulin till the patient is able to eat, and the insulin infusion can be continued for 30 to 60 minutes, after which subcutaneous infusion can be given. Always look for precipitating factor. Okay, this is a algorithm which will help us in treating this with the fluid. The fluid management in this diabetic ketoacidosis is little challenging. Always don't go with overhydration, because look at the status, kidney status, heart status of the patient, whether he is having LVF4 or not, or he having CKD. Always think of hypo. When look at this chart, we will go through this chart. When the patient is having hypovolemic shock, we will start on administering 0.9 of sodium chloride 1 liter per hour, and or other plasma expanders. If the patient is in mild hypotension or cardiogenic shock, we will evaluate the corrected. We will look for the corrected. Sorry for the scribbling. Corrected serum sodium levels, and serum. If the serum sodium level is high or normal, then we will administer 0.45% of sodium chloride, and the rate at which to be done is 7 to 14 milliliter per kilogram per hour. And once the sugar sugar values is below 250, we can administer dextrose, 5% dextrose along with 0.45 saline, and the insulin should be at a rate of 0.05 to 0.1 infusion. And our aim should be to keep the blood sugar value between 150 and 200, and it should be checked every 2 to 4 hours. Okay, and once the patient is okay, we can convert it to subcutaneous regimen. And insulin can be either given in IV route or subcutaneous route. For IV insulin, we can give 0.15 unit per kg as IV bolus, and regular insulin is usually preferred. That is our plain insulin. 0.1 unit per kg is infusion. If blood glucose level does not fall by 50 to 70 milligram, we have to repeat this until the glucose values are below 250. For subcutaneous route, the insulin values will be a bit higher, and potassium correction is potassium correction is little challenging in these patients, because we have to continuously monitor the potassium level. When insulin is initiated, potassium will go down. So if it is less than 3.3 milliequivalents, then hold insulin for some time and give 40 milliequivalent of potassium per hour, and look for the values. And if the serum potassium level goes beyond 5.5 milliequivalent, don't give extra potassium. Check for every 2 hours. Our main aim is to keep it between 3.3 to 5.5, and once it is okay, we can continue with 20 to 30 milligramms of potassium. Okay, that's a brief discussion on that diabetic ketoacidosis. This is a 82-year-old lady who's staying alone and is on OHA. She was admitted to your hospital with history of confusion, fits, and her glucose values are very high, 780. And blood analysis shows there is absence of ketonuria, and her pH is 37.3. So, and her sodium levels are very high. This suggests that she is having dehydration and severe dehydration. So, HHH, hyperosmolar hyperglycemic state, previously known as HONC, is most commonly in elderly who are type 2 diabetic and who are neglected or living alone, or who is not receiving fluids in hospital. For everything, the precipitating factors should be found out. Our main objective should be to find out the precipitating factor. It may be either infection, stress, hypovolemia, or failure, or inadequate fluid intake, or inadequate accessibility, or incapacitation. The 4 primary things that we see in HHS is that severe hypoglycemia, absence of ketosis, profound dehydration, and neurological manifestation. More than that, we will see in type 1 diabetic ketoacidosis. So they will be having lesser GI symptoms. That respiratory, emphysema respiration is seldom observed. The focal neurological deficit will be more in these patients. And the laboratory findings will suggest that there will be very high glucose. Ketone will be usually negative, elevated osmolarity, and the treatment aim is insulin management, treat the complication, hydration. Okay. This is another case of 44-year-old male who's a type 2 diabetic for last 8 years, and who's on glibenclamide twice daily and metformin 1 gram daily. And his fasting sugar is 96 and his postprandial sugar is 126. His complaints of headache, inability to concentrate, and nervousness at around 4 p.m. every day. These symptoms disappears after taking a toffee, something sweet. So it is a case of hypoglycemia. Whipple's triad suggests that symptoms of hypoglycemia, recovery with high carbohydrate, and documented low blood glucose level. Actually, the hypoglycemia can be classified into step 1, step 2, step 3. Step 1 hypoglycemia suggests that the patient is having glucose level of less than 70, but he is conscious oriented. Step 2, it is less than 54, he is conscious oriented. And step 3, patient is unconscious. And for the conscious patient, the rule of 15 is usually followed. We can give 15 gram of glucose and recheck after 15 minutes. If it is less than 50, we will repeat it for 3 times and recheck after 15 to 20 minutes, and we will see whether it is getting better. If the patient is unconscious, intravenous route is usually taken. Either 50 ml, 50% dextrose, or 25 ml, 100 ml, 25% dextrose will be given rapidly, and check GRPS or after 15 minutes, and we will see if it is less than 70. If it is less than 70, repeat this thing until the blood sugar levels are 70, and maintenance of with 5% dextrose or 10% dextrose may be done with oral feeds. If there is no intravenous acts, administer 1 milligram of glucagon subcutaneously. Recent studies say that up to 3 milligram of glucagon can be given. And our main part is prevention. Being a primary care physician, our main part is prevention. Always explain hypoglycemic symptoms to your patient, because whenever they take sulfonylureas or insulin secretagogues or insulin, they are at risk for hypoglycemia. So they should be advised regularity of diet, insulin, and exercise. And between meals, snacks, and bedtime snacks can be advocated if they are facing this problem. They should be asked to keep a regular follow-up of their blood sugar values and keep all these things, that sugary things, with them. And education is very important. And analog insulin can be used in patients who are taking plain insulin or other insulin, because this tends to be less hypoglycemic. Now we will be going through the microvascular complications of diabetes. The basic pathology for all the microvascular complication remains the same. That is, there is progressive narrowing and occlusion of vascular lumina. There will be impaired perfusion, ischemia, and tissue damage. And the microvascular complication, the cells affected in retina are endothelial cells, pericytes, Mueller cells, and ganglion cells. And renal cells, it is mesangial cells and podocytes. And peripheral nerves, Schwann cells, endothelial cells, and pericytes are involved. This is there are 2 case scenarios which we will discuss. This is a 69-year-old male who is type 2 diabetic for 16 years on Glimi and metformin, and he presents with you with polyuria, and his BP is 160, 100, and weight is 70, height is 164, and his sugar values are 210, and his HbA1c is 1%, and proteinuria is 1.1 gram, and his retinal examination gives NPDR. So this is a case of diabetic kidney disease. So, and this is another case of patient coming with proteinuria, but here the duration of diabetes is less and there is no retinal changes. So this will suggest that it is not diabetic kidney disease. It may be any other disease. So when to suspect a non-diabetic kidney disease in a patient with diabetes. So it is short duration of less than 5 years, absence of retinopathy, and whether there is grossly elevated lipids, and there is active sediments in urine, and there is history of clinical features of primary renal disease. So we can have one formula for MDRD formula for EGFR calculation, but it is not at all required nowadays because we have our fonts which will give, if you put the creatine value, they will give the values, but chronicity so we can go through it, note it, because it may be sometimes helpful. And there is a definition for chronic disease when the EGFR value is less than 60 ml per milliliter per 1.73 meter square for more than 3 months. It is defined as CKD. So diabetic kidney disease, it is either albuminuria or reduced EGFR with history of long duration of diabetes without primary. We have to be we have to know the risk factors for diabetic kidney disease, because being a primary care physician, our main aim is to prevent nephropathy. So now we have to control hypertension, control hyperglycemia, control microalbuminuria. Duration of diabetes is one factor which will aggravate, which will make the patient more prone to diabetic kidney disease. Family history of similar illness in family, ethnicity, and cigarette smoking. Cigarette smoking is a important factor adding on to this, and hyperlipidemia. Our treatment aim is to control the glycemic value as much as possible, for that the complication doesn't develop. RAS blockade to prevent further progression of kidney disease, lipid control, blood pressure control, diet control. Diet control has been proven benefit in both type 1 and type 2 diabetes. Always reinforce this dietary habits in patients. So few words on which all drugs to be caution with in diabetes patient with CKD. Metformin is contraindicated if EGFR value is less than 30, and reduced dose if the EGFR is between 30 to 45. Sulfonylureas to be avoided, but if at all using short-acting things like glipizide and glucoside may be used. Ripaglinide is safe in kidney disease. Glitazones and carbos should be avoided. SGL2 and GPL1 receptor agonists are beneficial in preventing progression of the disease. If we are using sitagliptin, saxagliptin, and vildagliptin, this dose should be adjusted. Linagliptin and tenligliptin can be used without dose adjustment. And insulin is safe for any EGFR, but be cautious using the insulin. Start in minimal dose and increase the dose accordingly. And microalbumin testing should be done in type 2 diabetic patient at the time of first when you detect diabetes, and it should be followed up every yearly. And microalbuminuria in type 1 diabetic patient can be done every started 5th year of identification of diabetes, and it should be continued every yearly. And always look for microalbuminuria because it's early stages of diabetic glomerulopathy, and at this stage it is reversible. And the blood pressure should be kept below 140/90. But if the patient is having other risk factors like CVDs or other risk factors, it should be kept below 130/80. And the best drug for that is AC inhibitors and ARBs. And recently studies state that mineralocorticoid finerenone has been shown to reduce progression of diabetic kidney disease and proteinuria in type 2 patients. Dietary modification, there should be a protein restriction so that the filtration, hyperfiltration, and intraglomerular pressure is reduced. And the protein restriction should be 0.8 gram per kilogram per day, 0.6 to 0.8, and sodium restriction less than 2.3 gram per day. And always avoid nephrotoxic drugs, prevent dehydration, avoid smoking, early and aggressive treatment of UTI in a patient with diabetes, which will worsen their renal status, and restriction of sodium phosphate when it is indicated. Always control other things like lipids and hypertension. And when to refer, if there is a rapid rise in creatine or hyperkalemia and a rapid fall in EGFR, then definitely the patient should be referred to a nephrologist. And few words on diabetic retinopathy. These are microangiopathy due to prolonged uncontrolled hyperglycemia. These patients present very late to us because it is usually not looked for, and their symptom, they may be asymptomatic. When their macular region is affected, they will have some problem of diminishing vision. Otherwise, they will present with bloaters, floaters, etc. And the classification is NPDR and PDR. It can be NPDR can be early mild, moderate, and severe diabetic retinopathy. And there are certain factors influencing the cause of diabetic retinopathy: duration, glycemic control, hypertension, serum lipid values, renal disease, pregnancy, anemia. All these contribute to aggravates this the retinopathy. So retinal examination in type 1 diabetes should be done within 5 years, as we said for that renal thing also, 5 years after diagnosis and every year 1 to 2 years thereafter. And type 2 diabetes retinal examination should be done at the time of diagnosis and should be followed up every year, and always take an opinion from an ophthalmologist if they detect any other lesions. And there are certain other non-retinal ocular manifestation: cataract, anterior ischemic retinopathy, diabetic papillopathy, ocular motor movement disorders, and all these should be you should be aware of the things that these are all things are also there. And there are certain conditions for which diabetes is risk factor, like glaucoma, ischemic retinal artery occlusion, retinal embolism, retinal vein occlusion, corneal disease, etc. So coming to the next complication, it is the most common and the first thing to occur, that is diabetic neuropathy. It is most troublesome for all diabetes, and it is the painful complication. More than 50% of diabetic patients will have this peripheral neuropathy or diabetic neuropathy. And the thing is, it is painful, and erectile dysfunction, which is a part of it, is a hidden complications. The definition suggests that the presence of symptoms or signs of peripheral nerve dysfunction in the patient with the diabetes after exclusion of other diseases. Always know that diabetic neuropathy is not a single entity. It may be there may be aggravating or associated features of nutritional deficiency along with diabetic neuropathy. So the classification is diffuse neuropathy, mononeuropathy, radiculopathy, and non-diabetic neuropathies. Of this, diffuse symmetrical polyneuropathy is common one, and that is what we usually see. And this mononeuropathy may present as cranial nerve palsies like third nerve, and sixth nerve palsies. Okay, the diffuse symmetrical polyneuropathy is the most common presentation, and it is a chronic sensory motor, but initially it is the sensory, which presents as claw and stalking. Later on, it will affect the motor part also. And few words on clinical manifestation: autonomic neuropathy. It may be cardiovascular or GI. Cardiovascular, the patient may present with tachycardia, cardiac denervation, and orthostatic hypotension, skin temperature reversal, dry skin, and dependent edema. And GI, it may present as gastroparesis, constipation, diarrhea, or fecal incontinence. The management is good glycemic control, symptomatic treatment of the pain, and agents that can help in restoring the nerve function and avoidance of nerve toxins. Coming to the macrovascular diseases in diabetes, macrovascular diseases affects large arteries, commonly coronary artery disease, peripheral artery disease, and stroke. All these have 2 to 4 times high risk factor when compared to general population. It is multifactorial. We have to know control hypertension, control obesity, psychological stress factors should be controlled, alcohol consumption should be stopped, smoking cessation should be there, cholesterol level should be controlled, increased consumption of fruits and vegetables should be advocated, decrease in alcohol should be advised, control of diabetes, good physical activity should be there to prevent this. There is a ticking clock hypothesis suggests that microvascular complication starts once the onset of hyperglycemia. But for macrovascular diseases, the clock ticking even at the pre-diabetic stage. Yes. Okay. Coronary artery disease may present as stable angina, unstable angina, variant angina, anything. It may present as acute myocardial infarction, Frank. But there are certain peculiarities in diabetic patient that it may be silent or it may present as atypical angina equivalents at younger age. It may involve all blood vessels or small vessels, or the complications are more common and outcome is very bad with revascular procedures. There are strategies for CAD risk factors. Our aim, being a primary care physician, should be to early diagnosis of diabetes, good control of diabetes, control of their lipids, control of their BP, aspirin whenever indicated, dietary modification, exercise, weight reduction should be emphasized each and every time you see a patient, and addiction should be avoided. Relaxation techniques should be advised each and every time. The diet, weight reduction, dietary modification should be emphasized to each and every patient, even without knowing their diabetic status, because it will help in preventing all these diseases, metabolic diseases. So our major goal of treatment is to increase the coronary artery perfusion, decrease the myocardial workload, prevent myocardial infection, disability or death, and intervene in case of unstable angina. Now we will see two case scenarios. This is a 58-year-old male who has been diabetic for past 24 years, and he is a chronic smoker, and he smokes about 20 cigarettes per day, and he complains of severe pain in the right leg, which develops when he walks for 50 minutes, and pain subsides on taking rest. This PAD, we know it is a peripheral artery disease because his posterior and dorsalis pedis are not not palpable. This is another patient who's diabetic for the past 12 years. He had a trauma to his leg, and there is a wound with infection, and it is a ulcerated wound which has intruded the bone. So, and his examination revealed that the monofilament test is positive, or vibration sensation at 128 Hertz is absent, his angle jerk is absent. So these are two conditions, the peripheral artery disease and diabetic foot, which goes together. So PID, the common contributing factors are smoking, dyslipidemia, uncontrolled hypertension, obesity, which is mainly truncal associated renal diseases, and high lipid levels. The signs which we should always, signs and symptoms, being a primary care physician, we should always know that intermittent claudication, nocturnal pain, non-healing ulcers, absent pulse or cold feet, gangrene, loss of hair or hair on the legs, shiny atrophic skin, and thick toenails, all these should be noted and should be identified at the earliest so that we can prevent this. And they point to note that claudication and rest pain may not be prominent in patient with neuropathy. Diagnosis is with angle brachial index, which we can do at our OPD, and color Doppler angiogram, MR angiograms, CT angiogram, or DSA. Anything can be. The management is relieving of the pain with vasodilators and other drugs to reduce the pain. And if there is a clot, thrombolytic agents can be used. If there is obstruction, angioplasty can be done. If no other option, bypass surgery can be done. Now coming to the principles of diabetic foot management, always look for the stages of ulcer if there is this present, and prevent development of risk factors, good glycemic control, lipid control, and good foot care practices. High risk foot, proper footwear, cones and calluses should be removed early under supervision. Metabolic control of diabetes and other parameters, patient education, and good foot care practices. There are staging, 6 stages. One is normal foot, no risk factor. Other one is high risk foot with no ulceration, but past history of ulceration may be there, and ulcerated foot with screen breakdown, which may present as ulcers, blisters, or fissure. Up to here, we can manage both this. It is better to refer to a foot clinic. If you are confident in doing this procedure, you can do it. And this infected foot, 4 and 5 necrotic and 6 unsalvageable foot, above 5 and 6, definitely it should be sent to a foot clinic. Now we're coming to the cerebrovascular diseases. Diabetic patient may present as any of this. it may be either classical stroke, complete stroke, major or minor, or TAA. And the risk factors which should be prevented to help in prevention of the CVA. Always we know that the risk factors which we can modify will be helping the patient. And hypertension control, smoking cessation, diabetes control, dyslipidemia control, polycythemia control, decreased alcohol intake, oral contraceptive use in patient with diabetes are contraindicated. And diagnosis may be done with clinical evaluation in the first and imaging techniques in the late. Now coming to the management of diabetes, which itself is a big challenge. Diet, exercise should be primary part, and education. Drugs only comes after that. The ADA and RSSDA guidelines suggest fasting sugar to be 80 to 130, and ADA suggests 115, and RSSDA 80 to 130, and the postprandial sugar to be 180 and 160. HbA1c is common for both. What should be our aim? Our aim should be to correct the metabolic problem associated with hyperglycemia and ensure normoglycemia as much as possible, and identification and treatment of comorbidities at the earliest. And patient should be educated each and every time when you get an opportunity. And treatment of diabetes is always glucose-centric, but it should not be like that. At least the family physician should be multi-centric, because it is not their sugar values that we are treating. We should treat each and every thing, that the nutritional part, weight management, addiction prevention, everything, hypertension, everything should be looked into. And we will see a case scenario. This is a 35-year-old male who has impaired glucose tolerance, and he did his OGTT few months back, and is worried that he is going to get diabetes. His BMI is 37.5. What advice, being a family physician, will you give? So our intervention starts at his diet, and the steps in dietary intervention is assessment of his calories, which we can do with a 24-hour recall method of one in a holiday and 2 other working days, and determination of his other weight, height, weight, and other parameters. Calculate calories, make a meal plan for him, and follow up. It never force a patient to take a meal which we like. Always make a meal plan which the patient can adjust and which is available for him. Usually dietitians do what they like and what they ask them to eat. And the components of dietary management in diabetes is to do a good glycemic control, lipid control, and weight maintenance. The thing is to restrict calories, quantity and quality of carbohydrate, modify fat intake, which I will be dealing detail. The carbohydrate should be 50 to 60% of total calorie, and it should be complex carbohydrate. And refined sugars should be avoided. Low glycemic food should be taken, and there should be fiber which each carbohydrate may. And protein, as usual, 1 gram per kilogram, and it should contribute to 15 to 20% of diet. And non-vegetarian, vegetarian, the patient can choose, because it is his diet, he can choose it. And dietary fats and diabetes, dietary fat should be restricted to 30%, and saturated fat should be restricted to less than 10%. And trans fat should be best avoided, and monounsaturated fatty acid should be encouraged. This is a food chart which I used to prescribe to my patient, which is a diet. The one in the this one is our PK Sir's diet, and this is a Harvard Medical School's diet. They found out after a long research, and this is the diet which I have been hearing from him since 2007. So both are same, and I always prescribe a diet chart for my patient with what all things they can eat in a diabetic patient. So try to maintain a good dietary chart for a patient which he can afford. So exercise in type 2 diabetes, Miss Rajan is a 60-year-old male, and he has diabetes for the past 25 years, and he is hypertensive and hypercholesteremia, has dyslipidemia, and he leads a sedentary life. He heard from his friends about the benefit of exercise, and you are his family physician. What advice will you give to him regarding the exercise? So always make sure that the patient knows what exercise is. They will be saying that I'm doing this work and that work, which they attribute to their exercise. But always, exercise is a physical activity that is well planned, structured, repetitive, and purposeful, and usually aimed at improving or maintaining physical fitness. And physical activity is another different thing. It is any body movement produced by skeletal muscle that result in energy expenditure beyond resting expenditure. So it has a benefit, that exercise has a benefit. Reduction of weight improves bone, joint, muscle health, improves circulation, promote social interaction and interaction, reduce stress, improves functional capacity. So this is a wording from Suresh sir's talk, that fit answer the patient with fit. Fit means frequency, intensity, type, and time. Though the frequency at least 5 weeks per day, intensity should be moderate, and type of exercise should be aerobic and resistance training, and time should be 30 to 45 minutes, that is 150 minutes per week. And aerobic exercise 4 to 7 days per week, at least 5 days should be there, and it should be 20 to 60 minutes of continuous exercise, if not possible accumulated in bouts of at least 10 minutes. And resistance exercise, it should be a 70 to 80% of our heart rate, and maximum frequency of 2 to 3 days with a 48-hour gap in between, and the intensity can be done in 2 to 3 sets. Always limit the patient to their extent, the way, because many will be having ischemic heart disease, CKD, or any other complication. So their personal things should be taken care of. So not personal things, personal opinion should be taken. Patient education in diabetes. This is the most important part, which we should emphasize. Every patient encounter, we should be treated as an educational opportunity. And the components includes education regarding the disease. We should educating regarding the disease in each and every visit, because once you talk to a patient 100 times, they will follow for a single time. So monitor the diabetes, give them advice regarding when to monitor, when to come back to you their results, and information regarding the treatment options, and what the current treatment is, what all things can be added, what can be withdrawn when the diabetic status is controlled or worse. And information regarding complications should be advised, and ask them to meet you when they see any of the warning signs advocated to them. And always tell them about special situation like fever, any other hypoglycemia, hyperglycemia, foot injury, anything, or UTI, any infection, ask them to come back to you. And self-monitoring blood glucose should be advocated. Now coming to the anti-diabetic drugs which are available in India. These are the classes of drugs which are available for treatment and available in India: biguanides, insulin secretagogues, like sulfonylureas, meglitinides, thiazolidines, and alpha glucosidase inhibitors, DPP4 inhibitors, and injectable things, SGLT inhibitors, GLP-1 receptor agonists, injectable and oral, and other agents, and insulins. We will be knowing all of us will be knowing this. These are the classes of and their side effects and mechanisms of action, which hopefully everyone will be knowing. The primary agent for treatment of a type 2 diabetes is type 2 diabetic patient is metformin, and we can add according to their risk factors. So the first line being the metformin. The priority depends on each patient. If the patient's priority is avoidance of hypoglycemia, we can add any of this second line drug. Second line drug may be DPP4 inhibitor, GP1 receptor, GLP-1 receptor analog, SGLT, or thiazolidines, and we can add any of this. If another third line is to be added, metformin, one of this agent, and any other from this agent. And always don't combine DPP-4 with GLP-1 analog. If there is a fourth drug to be added, always pick from the thiazolidines or other drugs. But if we have to use more than 4 drugs, better to initiate insulin. And if the priority is avoidance of weight gain, we have to start on either GLP-1 agonist or SGL2 inhibitor. And the combination, if the third drug has to be initiated, we can use these two together. Never use, once again, I'm emphasizing DPP-4 and GLP-1. And when the fourth drug is to be added, always the sulfonylurea thiazolidines are to be advocated, but they will produce weight gain. If in our scenario, the cause concern is of prime importance, so the second agent is always sulfonylureas or thiazolidines because these are less expensive, and combination of the second line agents can be added. It is better if for these patients, if the cost is concerned, we can start them on NPH, which will be available in PHCs and CHCs. If they have other risk factors, then cardiovascular risk factor or any other risk factor, better to start to have metformin. Along with that, we can have GLP or SGLT to inhibitors because these drugs have beneficial effect. If the third drug is to be added, we have to do it, have a combination of all these 3 drugs. And if another one is to added, basal insulin or sulfonylureas, thiazolidines. If there is heart failure, SGLT2 is the best drug to be started, second line drug. And other agents can be added, but always be cautious using thiazolidines, saxagliptin, and alogliptin. If there is diabetic kidney disease, SGLT2 is the best drug to be added on metformin, and GLP, if not tolerated, GLP-1 receptor analog can be used, agonist can be used. And if third drug, we can use combination. And before adding on to fourth drug, always check for EGFR. If the patient is having CKD without albuminuria, again, SGLT and GLP-1 analogs are better, and third drug, these two can be combined. So always think of these drugs because the dose and all thing I know everybody will be knowing. So always go through this slide or go through these things when we start prescribing OHAs to a patient. And few words on insulin. We have human insulin, which can be regular, or NPH, which we usually use. And we know that one is clear and other is non-clear. And premixed insulin, which benefits the patient feel convenient because of the only 2-time pricking available needed. And there are ultra rapid acting analogs. These have better benefit because they will have better postprandial glycemic control, fewer episodes of hypoglycemia, flexibility in lifestyle, safer in elderly, and long-acting analogs like Glargine, Detromir, and all. These can be used because the hypoglycemic chances are very less, and we know that they are peakless and they are hypoglycemic. These are insulin preparation, which we have discussed, and the duration of action, half-life, and onset of action. The human regular insulin, it takes 30 to 6 minutes to act, and peak is 2 to 3 hours, and for act for 4 to 6 hours. Aspart 5 to 15 minutes, 1 to 2 hours, and 3 to 6 hours. Fluoxetine 5 to 20, 1 to 2 hours, and 2 to 4 hours. Lispro 5 to 15 minutes, 30 to 75 minutes, and 2. And the other things we know that Glargine, Detromir, and Degludec are peakless, and Degludec has an advantage of more than 72-hour action. Say insulin initiation, when to start an insulin, when there is OHA failure, when the patient is not compliant, we can start on insulin. And in a newly diagnosed patients who are symptomatic, the insulin starting guidelines are when the HbA1c is more than 9, fasting sugar is more than 250, and postprandial is more than 300, and when there is ketonuria, catabolic state, and pregnancy. Okay, and the regimens which we have is basal insulin, premixed insulin, basal plus, and bolus regime. So basal insulin regime, when the OHA is more than 3 or 4, we can have a basal insulin in the night along with this OHA. But the chance for hypoglycemia is very high. We can initiate it at 10 to 12 units or 0.2 unit per kg, preferably in the night or morning. whichever the patient feel comfortable. But there will be and their dose titration has to be done in 2 to 3 years. But the compliance will be less. But there is an advantage that the patient may not have much weight gain. And pre-mixed insulin patients will be liking this because they have better advantage, because better control of postprandial, and they are more acceptable because of their 2-time pricking only. And disadvantage is that hypoglycemia and less flexibility. So we can have this start on 10 units or 0.2 units per kg in the morning, half hour before prior to dinner, breakfast, and in the night before dinner. And we can adjust the dose according to these values. If the blood glucose is less than 100, we can reduce the dose reduce the dose by 2 units. If it is 100 to 1, no need to change. If it is 100 to 140, we can change to plus 2 units. And if it is 140 to 80, we can hike the dose to 4 units by 4 unit. And if it is more than 180, hike the unit by 6 unit. And if the human insulin is the more demand, the dosage is more than 20 units, we can split it to 2/3 and 1/3. If we are using 50-50 combination, then we can split it when the unit is 30 units above. So at last, when all the things are exhausted, we will ultimately come back to their basal bolus regime, either a NPH at bedtime and regular insulin 3 times, or a basal or long acting at bedtime and a rapid acting with each meal. And this can be given at 0.8 to 1 unit per kg. Half the dose can be given as NPH or basal, and half the dose can be divided in regular or rapid acting. And when there is hyperglycemia, we can increase the unit by 2 units in the morning and 2 units by in the night. And if the hypoglycemia, if there's hypoglycemia, we can reduce it by 2 units in the night and 2 units in the evening. So this is the HbA1c level of all the things which we have discussed. Diet and exercise, there will be a 0.5 to 2% reduction in HbA1c. And if sulfonylureas, it will be 1 to 2%, metformin 1 to 2, thiazolidines 0.5 to 1, glucose alpha glucose inhibitors 0.5 to 8, DPP-4 inhibitors 0.5 to 1, and SGLT 0.5 to 1. And incretins, this will be around an insulin 5% or unlimited. And don't be in a hurry to change your OHAs or in drugs, because it will take time. And the anticipated response time is secretagogues long acting, it will take 7 to 10 days, and rapid acting, it will take immediate action. And if it is metformin, it will take 2 to 3 weeks, and the fasting sugar will be an indicator for its control. Glitazoid 6 to 8 weeks, both fasting and PPBS, and DPP-4 and SGLTs, they will take 7 days and immediate. And thank you for the patient listening. It was a vast topic, and hopefully it was beneficial, helpful to all of you.
Thank you, Dr. Deepak, for such an extensive presentation. And you have to thank Anushri for sharing her laptop with you. Now you understand, right? Behind every successful man, there is a woman. Is it right?
Yes, madam.
Okay. I think, is there any time for discussion? There's one question I'll ask. Can you generalize taking HbA1c for all the diabetic patients? Is there anything you need to take care of? Because HbA1c, you know, is a very costly test, right?
Yes, madam. We have to individualize. Affordability is a big problem.
Yeah.
In our PHCs and CHCs and medical college, majority will be coming for medicines only, and they won't be interested in doing HbA1c. But for those patients who are affording, we can do. But better to do urine ACR than HbA1c, because it will.
HbA1c, I think it gives false values in certain diseases, right?
Yes, madam.
Anemia, yeah, hemoglobinopathies and all.
There will be, but the thing is, in medical college, their government is providing subsidies, and they will be doing it when they have the kit available.
Okay.
So the patient will have to have a low amount, I think 80 or 100 rupees for HbA1c.
Okay.
There is a diabetic clinic which helps them.
Okay. So you told about some government program, no? National program
Yes,
for
yes.
control. So are there any guidelines for that? At what age you should start checking or anything? Any protocols have given? I have no
Madam, in
idea
that
about it.
guideline, they say that everyone should be started. Should start screening if he is obese and if he's having any of the risk factor. But we do a general examination. If we see any of the features of insulin resistance, and if the age is less above 30, we have to screen.
Okay. Risk factors also? High risk factors?
Yes, high risk factors.
Family
which
history also.
we have
there,
discussed. If anything
strong
is there,
family history.
we have to screen the patient.
Okay.
But there is a program running now in Kerala by Kerala government. They are screening each and every patient with less than 30, and there is a news report in today's paper that there are about 1 lakh, that 30 to 50% are having either hypertension or having pre-diabetic stage.
Yeah.
And recently, I had a question from our Nema Sabha regarding data of the diabetic status control program and its benefits.
Okay.
Which actually I don't know, which I had to go through the majority of the programs which the Kerala government is running. And they found that around 40 to 50% of young people are having either risk factor for hypertension, diabetes, and 30% are having either pre-diabetic, and 20% of young adults are having diabetes.
Yeah. So Kerala, in spite of being a very literate state, where you see there is a poor health literacy.
Yes.
No matter what we say is they go for alternative treatment, easy methods.
Yes.
And by the time they present to us, yeah, they have all that micro and macro complications. So that's what I asked about the national program. So
Okay.
to which system they should go, and are they telling?
Yeah. And no, they are not. It is actually the program was started in 2010.
Yeah.
And it is running in our system, modern system. But recently there has been changes. The recent changes suggest that they can take opinion of AYUSH in prevention of diabetes and hypertension.
Okay.
Recently, that's after 1 or 2 years, these AYUSH people are running diabetes and hypertension, this NCD prevention clinics.
Okay. So time has to prove that.
Yes, and majority of patients will end up in CKD, DKD.
Yeah. Are there any questions from the audience? So many are asking for your slides.
Yeah, definitely, ma'am. I will share with Vishnu.
Yeah. Okay. So I think it's a time.
Yes, ma'am.
Yeah, okay.
And the video will be uploaded in our SpiceRoute YouTube channel also.
Okay.
Hopefully, this was beneficial, I think.
Yeah, definitely.
Sure, sir. It was such a wonderful case-based, informative session. Thank you so much, sir.
Thank you. Thank you.
Okay.
I also thank Indu madam for chairing the session.
Thank you.
Also a huge shout out, thank you to all the participants who patiently stayed in spite of the initial technical glitches. And sir's presentation was worth the wait. Thank you so much.
Okay, thank you so much. And good night all.
Okay, thank you, ma'am.
Thank you.
Thank you.